I'm Katie Young from Activate Care. You are one of the thousands of people participating in our SDOH Masterclass series. For that reason, and for all the work you do in your community, thank you. We hope you enjoy the show.
Hi, everyone. Hope you're having a great day, and thank you for joining us. This is Dan Kamick, Senior Director of Marketing at Activate Care, and we're excited to have you with us for today's SDOH Masterclass session, Community Platforms for Cross-Sector Collaboration. The SDOH Masterclass is a series of monthly webinars focused on the exchange of best practices, winning strategies, and cutting-edge tools in the field of social determinants of health, cross-sector data exchange, and systems integration for community health. Today's masterclass session is a really thoughtful and relevant discussion led by Mark Elson and Keira Armstrong of the consulting firm Intrepid Ascent, both of whom have deep experience in understanding and translating policy, workflows, and data in the field to help coordinated care interventions thrive. Throughout the call, we can take questions and comments, so please feel free to chime in with your thoughts if you'd like. We definitely want to hear from you. Just click the Q&A tool in your Zoom control panel and drop us a line there. We'll keep an eye on it, and if you have a question or comment, we'll try to write that in there. Recorded, and we'll get the recording out to you as soon as we can, typically within 24 hours. Activate Care, the host of today's masterclass, is a public health company based in Boston, Massachusetts, and we are on a mission to help the world act differently to achieve better health outcomes. We work with hundreds of healthcare, social services, and government organizations across the country, and we help them integrate health and social care systems in partnership with stakeholders across their community. And we try to help save their teams time while helping them improve health and social outcomes among the populations that they serve. And as you know, my name's Dan Kamick. I work in marketing here at Activate Care. I'm your MC today. I've been with the company for 5 years now, seeing this company grow from a scrappy startup in Boston to a national company now working with communities from coast to coast. Before this, I worked in a large FQHC or community health center in Boston called Fenway Health, which reminds me, you may have seen the recent viral video of the Boston area woman outside Fenway Park talking about voting with her donkeys. That's Boston for Dunkin' Donuts coffee. Anyway, that's our hometown, and it was a nice reminder for me to make my voting plan. And I hope you're thinking about that too, if you haven't voted already. And with that said, without further ado, I'd like to invite Mark Elson and Keira Armstrong from Intrepid Ascent to introduce themselves. It is really great to have you both with us today. And Mark, why don't you go first?
There we go. Hi, Dan.
Hey, Mark.
Thanks for inviting us today to participate. We've enjoyed following this series and your masterclass series, and it's a pleasure, a pleasure to be here with you and your team. So I'm the principal of our consulting firm, Intrepid Ascent. I have an educational background in anthropology. I have a PhD in anthropology. Did research on the insurance market in India and sort of socio-cultural dynamics of the insurance market there. And I lead Intrepid Ascent. We're a firm. We're based in California, and we work with communities to use and share data across sectors and across organizations to improve outcomes. And previously, I served in a number of leadership roles here in California in health IT policy. Let sort of Keira introduce herself next.
Great, thank you, Mark and Dan. Like Mark, I'm really happy to be here with you today, and we'll look forward to presenting a little bit, but hope also for an active conversation with all of you. My background is in health services. I had a focus on program evaluation and research, so both really interested in both qualitative and quantitative data. Most recently, I've been working with Mark for the past few years on the intersection between health IT and social and public health services, especially in whole person care communities in the last couple of years, supporting those communities to select and implement technology to really support the goals that they have for their specific local whole person care initiatives. And we'll be talking more about that later.
Thanks, Keira. So I will be speaking first here for a few minutes, and then hand off to Keira, and then we'll have discussion. And you know, we're really going to be focusing on the sort of cycle between policy, which can often feel remote and sort of top down, but the cycle of sort of feedback loops from sort of policy innovation to user experience and the experience of individuals implementing new programs and initiatives at the intersection of sort of health and social services, and really honing in on the critical importance of the community sort of level to sort of mediate user experience and policy innovation. And our primary example is going to be the Whole Person Care program in California. As Keira noted, we have worked and are working with a number of and have done some related work with the California Healthcare Foundation, looking at that Whole Person Care initiative overall as well. So I'm going to start off with a brief discussion of sort of the policy framework, and then Keira will delve into more sort of the user level, and we will then and pull it together then the linkages that communities are critical to mediate. Right, next slide, please. So, you know, policy can be sort of a dry seeming word and field in some cases, sort of oriented, you know, towards the past and the sort of codification of rules and regulations. But really, policy has, you know, at its best, has a more of a future orientation. And there's a definition here from the OED. Policy is a course of action or principle adopted or proposed by a government, party, individual, etc. So policy really is the form that our collective goals take as we make them practical. And we're seeing this happen in the space that many of us work in at the intersection of health and social services today. Next slide, please. So I want to start out with a question, and I'd like to ask you to respond over chat. And I want to give an example here over, you know, in terms of, you know, what is like a sort of a healthcare policy framework at the highest level. And so the question is, what vision emerged over the last couple of decades in the quality improvement world, and then became the leading lens for national health policy during the Obama administration? If you think you know, please type it into the chat. We'll say that, like, you know, almost every presentation from HHS and CMS used this framework. Was usually like slide number 2 or 3 in any presentations. We have some good responses here. Affordable Care Act, coverage expansion and affordability. Yes, those are both super critical, but I guess I'm thinking a little bit more theoretical. Okay, we have value-based payments. Okay, so not fee-for-service, right? So value-based care, yeah, that's definitely a component, but there was a, let's see, I'll give you a hint. There was a triangle, or it's a three-part framework. It has 3 components. Yes, there we go. The triple aim pulls this together. So let's go to the next slide. And this is just one version here of the triple aim. So better care for individuals and a better care experience as well. Some versions of this emphasize that, but better care with better outcomes for populations at lower cost. Oh, someone is saying now it's the quadruple. Right, I think there's like the fourth element would be, what is it, provider experience? Physician burnout, exactly, provider experience and burnout. So really this became an orienting vision that much of the policies then through that administration and that the federal government has carried forward in the last 4 years have aligned with. There's broad alignment around this model, I think, and there will be moving forward. So a question then for us today is really, and Dan, let's go to the next slide. Thanks. There we go. Yeah. So like what policy vision is emerging today at really the sort of intersection of healthcare and social services? We did a little bit of a word cloud here. We're sure there are other phrases that could also fit. One is whole person care. Another is social determinants of health, complex health and social needs. I sort of think of this as potentially, you know, the key concepts being, on the one hand, the coordination of services sort of across organizations and sectors. And the other side of the equation is for whole people, right? For whole person care. So people we want to, you know, people are holistic, and we want integrated services that can serve people from a holistic perspective in an integrated manner. And so, you know, hopefully someone on this call will come up with the triple aim of the future, right? to distill this sort of word cloud and these ideas that we're all sifting, you know, working on into a really powerful lens. And maybe that's already happened, but I don't feel like it's like it has, in the way that a set of ideas got pulled together so effectively with the model of the triple aim. So we're hopeful that will happen. And clearly there's a lot of energy in this area, regardless of whether we have an agreed upon sort of overarching name at this point. In California, we're going to talk about whole person care, which is a part of this. So if we could move forward. Whole person care, well, first of all, a lot of the sort of energy at the, you know, focused on services integration between healthcare and social services is happening in the safety net. And Medicaid has been a real leader here, partly because it's so obvious that vulnerable populations and Medicaid beneficiaries have needs that cross sectors. A lot of individuals on Medicaid have multiple touch points with not only the healthcare system, but allied systems. So whole person care in California was one attempt to pilot solutions to better integration of services to address these needs. It was a big program, and 27 counties participated. There was a lot of leeway given to pilots to design and implement their programs. And, you know, critically, whole person care enabled services to be piloted that were not reimbursed by Medicaid at the time. So there was a special, well, let's go to the next slide. Yeah, I want to just spend a little bit of time on this slide here. So what were some policy innovations of the whole person care program in California? There were a few. I think the first is the emphasis on services coordination. In particular, there was a focus on health and housing, and that had implications both at a program design level and also in terms of data sharing. And the state Department of Healthcare Services really required, had some requirements that promoted the use of new technology tools. For instance, you know, as other programs, you know, data sharing across participating organizations for care coordination was a requirement. But I think a sort of single item that was really innovative in this program was the requirement that every client must have a comprehensive shared care plan within 30 days of enrollment, and a shared care plan accessible to the entire care team. And these care teams were often, in most pilots, distributed across organizations and sectors. So that was a new challenge, an innovative challenge. The legal framework. The state issued a statute that basically said, share data to coordinate care for whole person care enrollees. And if that's what you're doing, then that mandate will take precedence over other state laws that may be perceived to be restrictive of sort of data sharing, And so in California, we have a complex set of laws. So that statute was actually really critical in helping compliance officers and legal counsel across the state kind of get over the hump and really get to yes on appropriate data sharing. There are questions as to how that statute will carry forward, but there's discussion about that. Client consent. Most of the health information exchanges in California are opt-out. They do not necessarily get consent up front for data sharing. They exist mostly in sort of a HIPAA world, but for whole person care with cross-sector data sharing being front and center, the vast majority of pilots in the state get consent from participating individuals and designed sort of near universal consent forms that were quite impressive. And so consent has been even added to the ability to share additional data beyond what the statute allowed. And this all occurred through local governance that was county-led, except in Sacramento, where the city led the pilot. County-led with stakeholder input and a framework of agreements and policies, procedures to support local governance and data governance. And then payment for services not covered by Medi-Cal that could be sort of tested out through this program, such as services for care management. All right, next slide. So here are some examples of innovative program approaches and a map of the first wave of the primary whole person care pilots in the state. I don't think I'm going to talk to these out of just given the time, Dan, but there's been a lot of innovation from a program perspective. Let's go to the next slide. So in terms of digital infrastructure, at a high level, there's been need for the pilots to be able to handle eligibility and enrollment, to engage in some degree of health information exchange, partly to pull in data for reporting then, and analytics and I think, another innovation of the program was really pushing sort of quality improvement type plan, do, study, act cycles, PDSA cycles. Pilots were encouraged and required actually to do PDSAs through the course of the program and improve program services over the 5-year life of the whole person care pilot. And of course, then the bullet on the right, care coordination and the design of care teams across sectors. All right, let's go to the next slide. One sort of unresolved or area where continues to be sort of both confusion and innovation is in there's the care coordination vendor space, and there's a lot of overlap right now between there's some overlap between care coordination vendors like Activate Care that are primarily or historically focused on enabling shared care planning across care teams, and then vendors that are oriented toward partnering with 211 organizations, for instance, to enable enable referrals to the social sector. And those vendors are starting to partner and in various ways to become more interoperable, and they're also starting to move into each other's space. I think some of this also goes under the name of community information exchange. Dan, did you want to make a comment here?
I do. Yeah, thanks, Mark. I just wanted to kind of reflect on the technology vendor experience with regards to this slide. I think this is spot on, and we've been talking about it amongst ourselves in recent days because it's a really nice kind of crystallization of what's happening right now in the market for these technologies. And I think from our perspective, we are sensing this tension between, as you state, care coordination tools and referral management tools. And really, we look at them as two sides of the same coin, I think, which is why we're increasingly integrating with kind of the pure play referral platforms out there that go by the names of Aunt Bertha and Unite Us and others. But I think the other thing, and we're sensing appetite for this too, is a need for vendors like us and those other vendors to really embrace open data exchange standards, right? Because what we can't afford to do, especially with this work, whole person care, SDOH work, et cetera, is to kind of replicate what happened with EHRs, right? Where there are walled gardens of a lot of really valuable data. And it took a whole nother cottage industry, the HIE industry, to kind of unlock just a little bit of that data. Yeah. So we really need to be much more comfortable and really set the standard around exchanging data, which is, we're integrating with Unite Us actually out on the West Coast, which is a really nice development. So
great. Thanks, Dan, for that perspective. I think that makes a lot of sense. I'm glad you're seeing the same thing. So let's go just to the next slide. And yeah, I just wanted to mention that we did last year, I referred to this briefly earlier, I think, but did a report with the California Healthcare Foundation on technology successes and challenges in whole person care pilots. This includes a couple of case studies, and my colleague Keira Armstrong was a key author of this. We think it's still pretty current, but it was published in April of 2019, and most of the research occurred in the months prior to that. But feel free to check it out if you're interested. All right. And so then where are we headed now from a policy perspective, sort of in California and perhaps more broadly? In California, in the Medicaid space, whole person care will likely be extended for one more year because CalAIM with COVID hitting, CalAIM is not ready to launch in January of 2021. So that's probably going to be pushed back to January of 2022 with a 1-year extension of whole person care to fill the gap. And the idea here is that to spread whole person care and related approaches more broadly throughout the entire state. And there's a shift in terms of who the lead entity will be from counties, which led whole person care, to the local Medicaid managed care plans for CalAIM. And through that shift, some of the services piloted through the waiver program of whole person care will become Medicaid or Medi-Cal benefits, paid for and in a different manner. And so it'll be interesting to see federally as well, if through the experiences in California and other states, through waiver funded programs like whole person care, the extent to which, or the rate at which successful ideas bubble up into or make that policy transition in terms of payment methodology to become benefits through Medicaid and other payers. And with that, I'm going to, I believe, hand over to Keira.
Great, thanks, Mark. Well, so Mark set the stage for how statewide policy is really pushing communities or providing communities the opportunity to take those kind of high-level goals and make them local. So the next section, we're going to talk about the ways that some of the whole person care communities that we've been working in have been both defining their community goals within that policy framework and then really doing stakeholder engagement at so many different levels and phases of their project to kind of try to innovate and make these program successful. So next slide. Just to give us sort of a framework for talking through different both phases and stages of community-led implementation, both of program and of technology. I'll be kind of dividing up examples into these different stages. So pre-implementation, or really looking at the program planning and setting up governance structure phase. Implementation of both program and technology tools to support the program goals, including community engagement and user onboarding. And then a post-implementation phase, which whole person care in particular has really set up to encourage continuous improvement cycles and evolving collaboration amongst these really diverse groups of stakeholders. Next slide. So one thing that we've seen in every whole person care, sort of required by the whole person care framework, was to set up backbone organizations or lead entities that really had that local discretion for whole person care implementation. As Mark mentioned, most of these were counties, and they were responsible for interpreting the legal framework, rolling out data sharing agreements, local governance structures, and many other tasks related to really setting up the agreement framework for the program to be successful. As Mark mentioned, both that cross-organizational consent has been a real innovation that will actually also outlast the whole person care statutes. A lot of counties have set up their consent tools so that they will kind of be the foundational tool for continuing that cross-sector collaboration moving forward. And then they also have been sort of the conduit for gathering end user input into both the program and technology aspects of their implementations. If you go to the next slide, some examples of pre-implementation engagement are, I think, two really good examples in different counties that we've seen are related to that consent. How do you develop a form that really speaks to people in language they can understand? And how do you, continue to train and support care providers to talk to clients or patients about what they're agreeing to, so what their information will and will not be used for, and how it can really help care providers collaborate to kind of identify which services people might be eligible for and get them into those services. So a lot of counties engaged in really detailed processes to develop their consent forms, and at many different levels. So both with care providers and with clients themselves about language and the process. Another example of engaging with the community and adapting the program to local context was around contracting and other agreements to kind of set up that framework in a local county. Often county leadership or whole person care leadership would had set up really detailed structures for having discussions about the data sharing agreements, just again as part of that foundation for changing perceptions in the county about what kind of data sharing is allowed with who. So data sharing agreements signed between organizations is sort of one level of those agreements. Consent forms to make sure that clients know what they're talking to is another. So setting up those structures with the active input of stakeholder organizations, so community-based organizations and others, has been really important. In one county in particular that I have worked with, they also worked really closely with their service provider organizations, in this case mostly housing service providers, housing and homelessness services, to redesign contracts to include these new program requirements. And it was a fairly iterative process, both to make sure they were considering all the right both requirements and support to ensure the success of this new shared initiative. Next slide. All right, so during the implementation phase of both the program and the technology, Counties have really served as a convening partner to identify the needs of the community and then to work together to find the tools to meet those needs. So one place we've seen just intense stakeholder participation has been in procurement processes. So the process to both identify the needs of the community as well as then go out and find the tools that can meet them. And then of course through the design, once they've chosen a tool, the design and build of that tool. So translating workflows into the new structure, really clarifying who and how can collaborate within those tools, and other examples that I'll go into on the next slide. And then we've also seen a lot of something very new, I think, or about the whole person care pilots is just the breadth of organizations that are collaborating together as cross-sector care teams for client care and are able to be then connected and working in a shared tool from really diverse organizations. And these have included, organizations from almost all sectors, housing, social services, homelessness outreach, food security, criminal justice, physical health, behavioral health, and some are even starting to delve into really how do you bring on board even more sensitive service providers like substance use disorder treatment and others. Next slide. So in some examples of how counties have engaged their stakeholders, in some counties when they were trying to decide on a care collaboration tool, they brought in the end user organizations, the organizations that were going to be required to use the tool for collaboration in some brainstorming and strategy sessions to design the request for proposals. So sessions where they all work together to kind of identify and clarify a list of required features. As well as then having those same organizations participate on committees that reviewed proposals and watched demos and did scoring and came up with the criteria for selecting a final tool. I've heard recently some really great examples of processes that have been used in addition to processes that I've been involved in on actually how to gather input on designing then and building out those tools for people to use. One county has had a committee of peers or people with lived experience to advise on how data should be displayed in a care plan or in a health record, a kind of community social determinants health record, to make sure that information is elevated when it's necessary for care team members to know to support the client's care, but is not necessarily offered right at the beginning, which might then influence the way care providers think about that client. And one example that I've heard recently was incarceration history versus a jail event. So the peers gave the feedback that it's, if they have an admit in the local jail, that is something they would want shared with their case manager right away, but that they don't want full incarceration history to be front and center in the care plan in case that would kind of affect the way the care team member even unconsciously thought about that person. Another thing that we've seen as a feedback from frontline staff and case managers across different whole person care projects has been really the need to be alerted for key events happening so they can help make care connections in real time. And we've seen different counties implement these in different ways, but some very common ones are inpatient stays at hospitals, emergency department visits, jail intake and discharge, and other, sometimes behavioral health crisis stabilization unit intakes and things like that. So those have been key feedback from care team members that counties were able to implement as part of these shared care coordination tools. Next slide. And then our team in some counties is able to do these really careful onboarding steps that really increases, we think, the success of different organizations being brought into this concept of cross-sector collaboration and really having all the levels of buy-in required, as well as chances to get all of their concerns answered. So in one county in particular, there's a readiness assessment step for the organization. Is the organization ready to come on to this initiative? Workflow assessments with different supervisors of programs to make sure that we're understanding how then best to train the users. We have kind of standard trainings, but we are able to adapt them slightly or provide examples that then speak to the workflows that we've learned in the previous step, as well as then providing kind of ongoing, we used to call it elbow support because we got to be at people's elbows in real life in person. Now we're doing virtual ongoing training and support to make sure that we're both offering continuous training as well as hearing feedback on how the tool and the processes are working for those teams. Next slide, which is a good segue to the post-implementation engagement. So a lot of these whole person care programs are really trying to engage with the end users of the technology and technology tools that they've implemented in an ongoing manner to either iterate and make improvements over time or assess if program changes need to be made. One of the roles that whole person care staff or supporters play is really triaging the feedback that they're getting from end users and from the community to determine, is it a technology issue or is it a program issue? Is it something that's part of the change management process, or is it a bug? Is it just that the tool's not working right in this moment in this particular way? Or is it something that maybe we need to help them think through workflow changes, or is a feedback on a possible program change? Next slide. And so, there are many, many ways that people are kind of asking for and offering kind of ongoing feedback. And there's one that I've kind of forgot to include in this list too, but use case documentation has been a really important one, like really defining what are we trying to use the tool for, so we have a shared understanding and we can really answer the question of why would I use it, especially in contexts where providers are having to use multiple systems at the same time. We're hearing this a lot in the housing field where HMIS systems are required for reporting to HUD, but you can't do that cross-sector collaboration within HMIS, just like you can't do that cross-sector collaboration in EPIC or other electronic health records. So really helping people clearly state the reasons for using these care collaboration tools and kind of keep their eye on the added value of what they're trying to do in each of the tools that they're working with. Elbow support has been a really helpful strategy for both offering ongoing training, but also hearing and seeing exactly what people are seeing and doing in the tool itself and getting feedback on how it's working for them. We often have people share their screens, so we see the tool from their perspective rather than the way we see it on our screen, because it's often different. And it really helps identify where they're encountering kind of bottlenecks or too many clicks or having trouble locating information, things like that. Some counties have implemented super user work groups. They kind of act as mini focus groups, ongoing focus groups to gather up information from the different users in their organizations and feed them back up to the program. Some counties also kind of build that into their case conferencing meetings, which some have implemented case conferencing meetings as part of the programmatic implementation, bringing case managers together to solve difficult cases or offer support on difficult problems that clients are facing. And sometimes that can include kind of a standing agenda item on the tools that support. And then, ongoing help desk support. So just keeping track of what common issues are and whether we can either change our approaches to supporting in training or elbow support or other ways. So if they're kind of tracking help desk tickets and making sure that those are being, that we're developing kind of longer term, bigger strategies for addressing them if we see patterns. The one I forgot to put on here is data. Reflecting data back to end users can sometimes help also with clarifying either programmatic requirements or identifying issues that are coming up. And so that's, you know, one of the things that we're seeing is really trying to engage with users and care providers on this issue of that Mark kind of laid out as the future vision of, or the evolving policy vision of supporting whole people, is really trying to figure out how to integrate services across our local communities to connect people to the services that they need. So integrating those services to be able to respond to the whole person is really the work that's happening at the community level. At this, we'd love to open it up to questions, and I see one here in the chat that asks, do you think that state policymakers considered the breadth and depth of end user experience refinement that would be needed for whole person care? You know, I think it's a really good question. And I think one of the things that Mark's definition of policy at the beginning indicated is that policy can not just be a method of kind of codifying the past, but really encouraging innovation. And whole person care counties, I think, have stepped in enthusiastically to embrace that innovation. And I think the lead entities at least had a pretty good, some of them, the ones that we've worked with that I know about, have had a really strong vision that they are asking a lot of their partners and trying to provide the support to bring them along with them. You know, that this is really breaking down silos that have existed for decades. It's really trying to do work that might not be comfortable. So I do think that has been part of the purpose of these Medicaid pilots, is to encourage innovation.
And yeah, and I would say that it was, this is Mark, just that, you know, I'm not, yeah, Dan, thanks. I think you asked that question. And we don't have a window into the policymakers, like how they came up with some of the requirements for whole person care at that time. But I think that they sensed that there was a gap in the market or in services being provided in communities, and for instance identified, you know, shared care planning as a key need for the success of the program, and they did that accurately. I don't think that they had a sense for then how hard it would be to pull people together and implement that type of those types of tools. But you know, that's not necessarily their role to know how hard something is going to be, right? And it was a pilot program. So another question we have here is, how are public health information exchanges utilizing your tools? I think.
Can I just clarify one thing before you answer that question, Mark? So one thing I do want to point out is that different counties are selecting different tools to do this work. So across counties that we work with, for example, we've seen, you know, lots of different vendors. So it's just want to say that before we start.
Yeah. Okay. So Peter, yeah, so thanks for your question about, I'll just repeat it. Do you know to what extent public health, i.e. local health departments, have been engaged in these efforts? Yes, so in the public health has been sort of on the sidelines. I mean, public health has been involved, given that they are often a stakeholder within local health departments. Many of the local health departments in California, you know, they have a public health public health, as well as they provide and have a healthcare services division, and it's the healthcare services divisions that really have led this effort, with some degree of involvement from sort of the public health arm of within the counties. And the public health has had more of a traditional focus more on monitoring, doing surveillance and interventions that are focused at the population level for every sort of citizen in their jurisdiction. Whole person care really focuses on a specific subset of the Medicaid population. And so I think while public health has been very interested in some cases, it's the leaders have been in the healthcare services divisions within local health departments. Keira, do you have any thoughts on that question?
No, I agree with your assessment. I think one of the challenges of whole person care has been in some counties, depending on their health information exchange infrastructure, has been gathering enough kind of utilization data to do reporting. Some counties have a lot of that set up and others don't. And I think that level of information might be of more interest to public health. I think some counties have had some users of the care coordination systems from public health if they do things like public health nursing, or have some users who might be collaborators on specific client care plans. But from kind of a big health and public health information exchange level, I think it hasn't reached that level of connection yet.
Yeah, I also with responses to COVID, we have seen in a couple of counties that whole person care funding is being used to enhance the reporting of COVID results, especially for the whole person care enrolled population. But there's a larger benefit there. So COVID has created, in a couple of cases, some points of connection, including I'll stop there.
And earlier we had a question just about the whole person care program and its younger sibling, CalAIM. Is this a fixed initiative, or is there a threat for dismantling this with the next / current administration? Mark, I just wanted to be sure everybody could hear the answer that you typed into that. So do you mind just kind of talking about that, the prospects of care into CalAIM?
Yeah, and in California, we haven't even received approval for the 1 year or an extension of whole person care into 2021 yet. There's a sense that will come after the election. We all assume that there will be an extension to bridge to CalAIM, but will there be additional budget from the feds, as we've asked, or will it be a no-cost extension? The answer to that might depend on the federal administration. I think it's pretty close. Well, people are confident that there will be, at minimum, a no-cost extension of whole person care. And then CalAIM, my understanding is that it has been approved. There have been extensive discussions between CMS and the Department of Healthcare Services in California that would have included some level of CMS approval. But I don't have a window into that. I would think, though, that given that CalAIM won't go live until 2021, at least that's when we think it would go live at this point, 2022. I may have gotten my years wrong earlier. We don't think it will go live for a year from January 1st. So that'd be the beginning of 2022. That the composition of the next federal administration will be really important, or will be impactful on how the design and gets finalized. And but is there a threat of CalAIM completely coming off the table? I don't know.
I just want to add one other thing to that. I think in some counties, depending on the complexity of their Medi-Cal managed care plan landscape, there is some concern about how the services transition to being covered benefits under managed care plans. So that, I think, is just one of the ways that it could change, and there's a little bit of anxiety about the change. I think a lot of counties have developed some really innovative and effective comprehensive or intensive case management programs that fill gaps that are currently not covered, and whether and how those get kind of fully transitioned and to the managed care plans is a question.
That's a really big question, and either they get transitioned or they get funded via the, but continue to guided sort of through health departments, through the counties, but sort of funded through the managed care plans is another possibility. And so there's a lot of active discussion happening between managed care plans and DHCS and counties, thinking about how to maintain services that have been built in an effective way. But there certainly are questions, especially given, as Keira discussed, the role of having a healthy stakeholder environment for decision making and buy-in, given that services are occurring increasingly and need to be occurring for these programs across organizations and sectors. So any potential change to the lead entity that's created sort of a local governance structure for shared decision making is potentially a very big deal with some opportunities, but also some risks if that transition is not handled well.
And we are seeing, a lot of interesting engagement from managed care plans to really understand what's been rolled out under whole person care, so that they can build off of current infrastructure, as well as creative solutions from counties to try to cover services in different ways if they don't think they would necessarily be services that would transition well to kind of the managed care arena. So things like maybe some of the housing services that have been developed, or some of the kind of mild to moderate behavioral health care case management that doesn't fit kind of traditional definitions of the types of behavioral health case management that are covered by either counties or health plans. So people are in the creative covering stage right now, trying to figure out solutions.
I bet we could take probably an hour to discuss managed care and all of this, and an hour to discuss the behavioral health care ecosystem as well. We're just at the top of the hour for this call, so I wanted to thank you, Mark and Keira, both for your time and for sharing your insights and experiences from the California experiment, we might call it. And if you do have any questions to folks online, feel free to email us if you want to dig into some more detail there. This call was recorded. We'll get that out to you within 24 hours. And thanks everybody for joining us. Thanks again to Intrepid Ascent for your partnership on this. And to everybody on the line, thanks for all you do in your communities, and have a great day.
Thank you so much for watching. If you enjoyed it, you should let us know. Head over to our website, activatecare.com, and use the chat box to connect with one of the friendly folks in our team. We're here to help. It takes a community.